on that note, thank you all for joining us. If you're intending to be at the COVID-19 Critical Care Training Forum put together by ATS, you're in the right spot. I want to start off by saying thank you all for joining us. It's at least in some parts of the world late on a Tuesday night, and everyone's busy clinically and academically and with other responsibilities in their daily life. And so we appreciate you taking the time to join us. We hope it'll be worth your while. We have a fantastic group of speakers that I'll introduce in just a couple of seconds. My name is Andy Admon. I am a first-year faculty member at the University of Michigan, where my focus is on critical care epidemiology and health services research. I was drawn to this topic and this group both because of my clinical work, but then also in my work on the ATS Members in Transition and Training Committee, led by Sushma Cribbs, and some of the other folks in this group are involved in that as well. So without too much delay, we have a full schedule for the evening. I'd like to introduce our first presenter, who's Dr. Elyse LaFond. Dr. LaFond is a second-year pulmonary and critical care medicine fellow at Weill Cornell Medical School, whose clinical and academic interests really focus on post-ICU care. She has been spending a lot of time taking care of inpatients with COVID-19 related critical illness and other critical illnesses over the last couple of months, and recently has also been spending a lot of time taking care of patients in the post-ICU setting as well. With that, Elyse has a clinical case to get us started, and so I'd like to turn it over to her to talk to us about it.
Excellent. Thank you guys so much for having me. Let's see if my screen share works here. Okay, is that working?
Perfect.
Okay, great. So thank you guys again for having me. Really excited to be here. I'm going to get us started today with a case presentation to sort of give everyone a context before we hear from all of our other speakers. My patient, for the sake of this presentation, we'll call Sarah. She's actually a patient who I took care of in the hospital as well as in post-ICU clinics, so it was great continuity. But she's a 40-year-old female. She's perfectly healthy, no past medical history. She has a normal BMI. She's an avid runner, and she lives in New York City, where she works as a speech pathologist for children. For about 1 to 2 weeks, she had developed what all of us will sort of recognize as very common COVID symptoms: fevers, cough, shortness of breath, overall fatigue. Finally, things got so bad at home in terms of her dyspnea that she presented to our emergency department. In the emergency room, she was febrile, tachycardic, borderline hypotensive, and she was working really hard to breathe. Respiratory rate of almost 40, using all of her accessory muscles, and even on high flow nasal cannula with a non-rebreather mask on top, she was satting 84%, and we shortly moved to intubate her and admit her to our medical ICU. For the sake of the conversation tonight, where we really want to focus on her post-ICU course, I'll try and go somewhat quickly through her medical course, but she shortly developed ARDS and had pretty bad refractory hypoxemia. We were treating her, of course, with the ARDS-NET protocol. She required about a week of intravenous rocuronium, and she was proned 3 separate times. And then at the peak of her hypoxemia, for about 48 hours, she required inhaled nitric oxide as a rescue therapy. In the middle of her stay, she developed what we consider to be a cytokine storm. All of her inflammatory markers were markedly elevated, and she developed new cardiogenic shock with a new EF of 10 to 15%, requiring both vasopressor and inotropic support. As if that wasn't enough, she also developed septic shock from a Pseudomonas VAP, for which we gave her antibiotics and max dose vasopressors. For her COVID-19 specific therapy, she received 5 days of Plaquenil up front. And then at the time of the cytokine storm, with the markedly elevated inflammatory markers. She also received 1 dose of tocilizumab. She ended up getting 2 doses of eculizumab because she had developed a rash on her anterior thighs. We biopsied that rash and it came back as complement-mediated thrombotic vasculopathy. And so she was given eculizumab for that, as well as started on a therapeutic heparin drip for the remainder of her hospitalization. By day 12, she had made what we all considered a miraculous recovery, and we attempted to extubate her. However, within hours, she was re-intubated for stridor. We treated her with 48 hours of steroids and then ultimately successfully extubated her exactly 2 weeks from the day that she had presented to the emergency room. She went to the gen med floor for a couple of days and then ultimately was discharged to our inpatient rehabilitation center, where she stayed for a week. And then 1 week later, she went home to her apartment in New York City, where she lived alone. So I saw Sarah in a virtual visit about 1 week after her discharge, which would be about 2 weeks after she was extubated. And for those of you who have done post-ICU visits before, this sort of model will be familiar, but we addressed all of these separate categories during the visit. From a mental health standpoint, Sarah was experiencing pretty significant anxiety and sadness. She knew she should be grateful to be alive, but she also felt guilty. Why had she lived and others hadn't? And she couldn't explain the sadness that she felt. She was having a hard time even getting out of bed at times. She had a lot of memories of the ICU, and she knew that she was delirious, when she was in the hospital, but she couldn't put together what had actually happened and what was a delirious episode. So we spent the first good part of the visit sort of putting all the pieces together and going through what had happened to her when she was in the hospital. Of course, because of COVID-19 visitor restrictions, she wasn't able to have any visitors when she was in the hospital. And so we were really the only people who could try and help her put all the pieces together. From a physical standpoint, she had experienced an 18-pound weight loss in nearly 2 weeks. And when she was admitted to the rehab facility, she struggled to even walk up front. She remembers it taking her 15-20 minutes to get 2 shoes on her feet. She ultimately was able to start ambulating short distances, but only with a cane. She had developed a new drop foot, which we think was probably a complication of her multiple proning episodes. And she had severe neuropathic pain in that foot. And finally, she was living alone and was unable to do things like cooking and grocery shopping. And so one of her friends had to move in with her into her apartment in order to help her with those tasks. From a cognitive standpoint, she's someone who was super sharp before she got sick, and afterwards sort of felt like she was in a bit of a fog. She was having word-finding difficulties, which was particularly upsetting to her given her work as a speech pathologist, and she described feeling just mentally exhausted, that she could only participate in conversations or interactions for short periods of time before feeling like she needed to nap for the rest of the day. From a medication standpoint, she had a couple questions. She had been discharged on apixaban 2.5 milligrams BID, and she wanted to know how long she should continue that. She had not had a proven clot. This was all empiric, sort of started at the time of the skin biopsy. She had had no DVT or PE. She also wanted to know if she needed to continue to take her metoprolol, which had been started for her new heart failure, every 6 hours because it was disrupting her sleep cycle. Her sleep cycle was already disrupted. She described waking up every 1 to 2 hours, which is about the proximity that I think we woke her up when she was in the hospital. So she felt pretty much exhausted at all times. When she could sleep, she told me that she had to sleep with her feet dangling off the edge of the bed because when her heels were resting on the bed, it reminded her of the position that she was laying in when she was intubated. On top of all of that, she was worried financially. She knew she wasn't going to be well enough to go back to work anytime soon, and she needed to speak with someone about how to apply for unemployment and other financial assistance. In order to try and help her, these are the things that we did. So we referred her to our virtual psychotherapy, as well as occupational and physical therapy services. And these are just very kind people who have donated their time and their expertise in the COVID era here in New York to do virtual visits. We referred her to our sleep medicine colleague who specializes in CBT approach to insomnia. We sent her to the neurologist so she could be properly evaluated for the foot drop, as well as pain management for her neuropathic pain, for which we started gabapentin. She went to the social worker to talk about applying for unemployment. We stopped her apixaban given that she was ambulatory for 2 weeks, which is pretty much our hospital, sort of what we've decided to do, I guess, at this point, since no one really knows. But if you didn't have an actual clot and you're up and moving around, even if it's slowly, we're stopping the anticoagulation. So we stopped her apixaban, and we were able to change her metoprolol from every 6 hours to every 24 hours to reduce her medication burden. And finally, we helped her get a PCP near the apartment where she lives so she doesn't have to travel too far. All of this stuff is, of course, on top of the medical subspecialty appointments that she has been going to and will continue to go to. She had to see ID because of the functional asplenia that accompanies eculizumab, and she was on prophylactic antibiotics for that, cardiology for the new heart failure, PM&R for the rehab, and so on and so forth. She ended our visit with this quote, which I found particularly moving. She said, "I've lived through 2 prior traumas, a divorce and living in New York City during 9/11. Those experiences were nothing compared to this." And with that, I will turn it over.
Great. Thank you, Dr. LaFond, for presenting that case. There's a lot, I think, to think about and unpack. We're going to have some time for question and discussion towards the end. In the meantime, for any of the participants, feel free to post your questions into the chat if you have them. I think to try to preserve as much time for discussion as possible, I'd like to turn it over to our next presenter, Dr. Jack Iwashyna. Jack's a professor of internal medicine at the University of Michigan, where a major focus of his work is critical illness survivorship. Clinically, he sees patients in ICUs at both the University Hospital at the University of Michigan and then also at the Ann Arbor VA Medical Center. And his talk, as you can see, is titled "A Dirty Dozen of Common Errors on Discharging Mechanically Ventilated Patients." So with that, I'll turn it over to Jack. Thank you for joining us.
Thank you guys so much for having me. We're trying to work my monitors here. So mostly what I'm going to do is repeat as slightly more generalizable phrase, the superb care that Elyse and Dr. LaFond just provided. And then also think about how can we build a checklist to help us do this in advance so it doesn't necessarily have to be done at the follow-up appointment, but it could be done, say, routinely before discharge. I should say that the work that I'm going to present is very much a curated set of ideas, and all the good ones were had by other people, including Andy Johnson and Carla Sevin, who are both on this call, as well as Joe McPeak, Jake McSparron, and Hallie Prescott. Sorry, I'm still figuring out the... All right, so 3 introductory slides. And the first is that fundamentally, our ICUs are set up to keep people from dying. Keeping people from dying is an incredibly noble goal. It's a beautiful thing, and I've dedicated my life to it. And so nothing I'm going to say is meant to suggest that death prevention is not a very important thing. But over the last 10 years, a number of us have been asking increasingly, what would recovery-focused critical care look like? And while on the one hand, this isn't anything particularly new, on the other hand, it kind of is. So the 2016 Surviving Sepsis Campaign Guidelines, which I think anyone who's willing to work as late as you guys are to be on this call has read, knows there's 67 pages, 655 references, 23 categories of evidence-based references, including detailed recommendations about selenium and carnitine supplementation, which are both important. But literally there isn't a single discussion anywhere in this entire document of post-discharge care. And that'll be corrected in the 2020 document, but it's just to say that the stuff is on the one hand sort of simple when I tell you, but on the other hand, as we all know, excellence often looks simple afterwards. Getting to excellence is less straightforward. And I could ask people to just check to make sure your mics are muted, particularly as your families wander through at night as you're trying to do this. I'd appreciate it. And so that we know through a careful set of studies over the last 10, 15, 20 years that there's a complex set of interactions of acute illness physiology, who patients were before, and the unfortunate limitations of even best care. And we all know sometimes people with COVID aren't getting best care, that lead to a cluster of syndromes that increasingly we think of as the post-intensive care syndrome. So it's new or worse organ failures, weakness, cognitive impairment, psychological problems, and then a set of problems around families. And we also know that those lead to what I think of as really the patient-centered problems that people are faced through increased risk of death, an inability to return to social roles, recurrent health problems, and burden on caregivers. And as Dr. LaFond pointed out, you can imagine very much how all of these are going to be Sarah's challenges for the coming years. And so what I'm going to try to talk about is a dozen things you can kind of run through a little checklisty style to try to help mitigate this. And they're going to come in 5 clusters. There's going to be a cluster about medications. There's going to be a cluster about follow-up. There's going to be a cluster about lines and tubes. There's going to be a cluster about making sure they can make it on their own. And there's going to be a cluster about education. All of these are available in a blog because I'm old. And so there's a blog on the Life in the Fast Lane blog. If you Google Life in the Fast Lane and Dirty Dozen, you can see where Andy, Carla, and I, and Jake and Hallie wrote this all up. So if you want a longer version. But let's start with some basic questions to ask about medications. And in particularly, are their home meds mostly restarted? We know we stop medications like crazy. This is some data from Ontario that shows that about 15% of patients who were in an Ontario ICU before COVID, who had been on levothyroxine before they were in the ICU, weren't on levothyroxine afterwards. Now, honestly, I have some good friends in Toronto. For all I know, there is a massive multi-year-long outbreak of iatrogenic thyrotoxicosis going on in Ontario. And so some of these stops were probably appropriate, right? Some of the stops of the statins were appropriate stops because people had LFT abnormalities. But it's hard to believe that 1 in 6 people in Toronto who came in because they were on who came in on Synthroid really needed it stopped entirely. It seems far more credible to me that those numbers were instead, there were a bunch of stops where because we stop it, because you can get away with it in a stopped in the ICU, right? And I like a tidy med list. Who doesn't like a tidy med list, right? You don't want all those holds in there from the outpatient setting. I can't find them what I'm looking for. But then do they get restarted? And then at the same time, you've got to ask yourself, think about the antipsychotics, the PPIs, the H2 blockers, the sleep aids, the opiates that we put people on, right? There's some VA data down there from Tony Coe that was just released in PLOS One, suggesting that somewhere between 2 and 5% of veterans who come through the VA who weren't on an antipsychotic beforehand and who have no psychological diagnosis nonetheless end up on an antipsychotic afterwards. These are not good drugs. We know how much of the opiate epidemic has a fundamentally iatrogenic component to it. So asking yourself, what were they on that it's safe to restart? And what are they coming out of the ICU on that should be stopped? And in particular, we have to remember how much the floor teams tend to defer to the ICUs. When we put someone on something like Haldol, they assume it was for a good reason, not just because we needed to get through the night. And when we stop something like Synthroid, they assume it was for a good reason, not just because we were trying to write only essential orders because there were 3 people crashing at the same time. And so it's incredibly important that we communicate a careful med rec that's not just about sort of simple med rec, but also says, here are the physiologic parameters. Because I'm going to kick you out of my ICU 12 hours after I get you off the norepi. And honestly, I practiced in a VA. If you were on 4 antihypertensives before I started you in the ICU, and then I put you on norepi, I take you off norepi, 12 hours later is not the time to restart your max dose of atenolol, your Lasix, your Bumex, and your ACE inhibitor, right? I will definitely kill you if I do that. So there's got to be a staged approach where we help people understand which were the intentional stops, which are the intentional holds, but please restarts, and which are the, oh yeah, no, we never meant to touch that at all. At the same time, and Elyse talked about this nicely, we've got to figure out what the plan is for anticoagulation. And in particular, we need to clearly communicate whether it was empiric or there's a clot found. You guys all love UpToDate. I love UpToDate because somewhere in UpToDate, they just tell you, here's all the evidence, but in the end, if you need to make a choice, here's what you need to do. Well, here's a reasonable strategy. And what I find hilarious is this afternoon's UpToDate card on anticoagulation, which basically says, it's probably something. Probably, I don't know for how long. And even UpToDate can't tell you. So there's got to be a clear plan because there's no way that the primary care doc who's working out of their home, whose kids are running around upstairs, has a better idea what to do about this anticoagulation than you do. And I'm thrilled that Cornell has some model guidelines and is following those and implementing those because it is incumbent on us when we start this potentially life-threatening medication that we hand that off to people who know, to people who have a plan to follow it up. Likewise, next cluster is about follow-up. And as bad as our life has been for the last several months, and Andy and I practice in Southeast Michigan, which for those of you who don't know your geography is pretty darn close to Detroit, it's been bad for primary care, right? All of their systems have been disrupted. And we're bringing in a huge number of socially disenfranchised patients who are becoming critically ill without having previously established primary care. So a simple plan that their PCP can follow it up, which honestly, I've written that. You've written that on discharge meds. You didn't feel good about it, but primary care can just sort that out. It's just not viable in a world where they may not have a primary care doc. And so you need to know who is the person they should call before their first visit. How are you going to hand off that information? I noticed that Dr. LaFond, on one of her circle of the things she did for Sarah, one of those was literally get PCP, by which I think she means find a PCP for this middle-aged, well-insured person. For those of you who work in social justice-oriented institutions that don't necessarily have strong insurance bases, how much worse is that PCP existence going to be? And then secondly is making sure we actually have the follow-up set up. Andy and Carla can tell horror stories about people who said, yeah, no, I definitely remember to get my cancer screening set up for that nodule you found out. And then you go, well, what about getting your dialysis? And they're like, no, I didn't get my dialysis started yet. I figured we'd follow up on that. And we know our patients' priorities aren't always our priorities. Are the lines and temporary devices all out? Here's the data from Vineet Chopra showing that in the pre-COVID era, when you routinely did a full physical exam on all of your patients every day for billing, 30% of the time, hospitalists were unaware of a central venous catheter that was nonetheless present in their patient. It's hard to believe that that's gotten better in the era of full sterile protection. And certainly I missed a femoral arterial line on one of my patients for 6 days until I had a new fellow come out, and that new fellow, Avni Kumar, who as Andy knows is meticulous, was like, we're gonna run the checklist. And I was like, you don't need to run the checklist. I've been very careful, Dr. Kumar. And she's like, yeah, we're gonna run the checklist anyway, Dr. Iwashyna. And on patient 4, we got to the femoral arterial line I hadn't taken out because I'd forgotten about it, despite having gowned up and examined him every day because I did the abdomen and I did his and his thighs. I didn't actually check his femoral creases. And then likewise, we have to remember that patients have been excluded, patients' loved ones have been excluded from the hospitals. So that stenographer at the side who's usually taking care and has a note about every time they were poked and prodded, that person's been banned from the hospital for the last few months for really good reasons, but we need to send them out with a written list of the lines, tubes, and drains that they had for this hospitalization so that whoever's doing follow-up can actually know what they need to work for. Meds, follow-up, lines. Then we have to ask, is there actually a plan for them to make it on their own? In particular, we usually think about OTPT as seeing patients in order to screen people for clearance and to screen for them that can get home. I'm not sure what New York's post-acute care looks like, but Southeast Michigan has basically stopped functioning. We no longer have STARS. We no longer have LTACs. We no longer have SNFs. We are now staffing our ICU on the assumption that we will be running inpatient LTACs for a lot of these patients. And so it's important to remember that the other thing OT and PT do is they help people figure out how to adapt to new problems. This is a patient of Vanderbilt's where they published this beautiful beautiful in a heart-wrenching sense, about a 49-year-old woman whose IQ dropped, Carla, you can correct me, I think on order of 35 points. And this is a CT scan of, I think, a 49-year-old. And I don't know a lot about the cauliflower or even that this is an MRI, not a CT. I'm sorry, Dr. Admon, that this is an MRI, but that's way less white and way more black than they're supposed to be inside the skull. The best data that I know of this yet is a piece in the New England Journal which said of the patients who've been discharged from a French group, 33% had a dysexecutive syndrome consisting of inattention, disorientation, or poorly organized movements in response to command. These are big, big flags that we're going to send people home to caregivers who have not been in-house, have not been getting educated that whole time about how to take care of them. And at the same time, there's an unprecedented economic dislocation. There's some new data out from the Institute of Social Research today that said of people who were employed in Detroit prior to COVID, 43%, 2 out of 5 have lost their jobs. This is the data from the New York Times. That's month by month unemployment going back to 1940. That big red bar there for April, that's only halfway as far down as it goes. So you have to ask, can they pay for the follow-up that they're going to need? And with our employer-based system that was stingy in the first place and the rise in unemployment as people move on to COBRA where they have to pay for themselves, you have to ask, are they really going to get the medications, the physical therapy, frankly, the basic food and equipment that they need to keep getting better at home? Because it doesn't matter if you prescribe it if they can't get it. Last cluster is education. This is Zudin Puducherry's very important work that I suspect everybody's here and that everybody here knows, and Elyse talked about this massive weight loss and loss of preferentially of muscle mass that occurs. These people, if you're not careful, are going to go home and they're going to think, I should just wait till I stop feeling so winded before I start exercising. I don't want to push myself too hard. And it's exactly the wrong advice. Many of us on the call are internists. We've been working with obese patients for decades. We know we don't tell obese patients to wait till you don't get winded till you start exercise. We tell you to start going in a structured way. Don't go out and try to run the Boston Marathon right away, but instead go out and push yourself a little bit every day. And we need to remind people that they basically had that similar massive deconditioning at a pace that they've never experienced before. We have to ask them if we prepared them for what we know are the big 5 things that patients are come in and can be readmitted for. Newer recurrent infection, CHF exacerbations, acute kidney injuries, COPD exacerbations, and aspiration pneumonia, all of which you guys know how to prevent. And we need to make sure we've actually given them information later. Because honestly, when you tell them it's time to go home, they're hearing one thing and one thing only, which is I'm going to get to see my family for the first time in weeks, and I can't wait to be the heck out of this hospital. And so they're not going to hear most of the education you give them. So the American Thoracic Society has put out this really wonderful 2-page pamphlet. That's what is the post-intensive care syndrome. Give it to them, give them the link, let them go back and look at it later. When 2 weeks from now, they realize they're still weaker than they thought they were. And they're starting realizing like, yeah, no, it's not just that I'm tired. It's my brain doesn't work like I used to. And then keep figuring out how to do this better. We are all making this up together. Anybody wants a copy of my slides, feel free to shoot me an email, or I'm told I spend more time on Twitter than is healthy for a professor. But also, as you're building a program, there are others of us who are out there working. Andy and Carla are leaders in something called the Critical and Acute Illness Recovery Organization, CAIRO, which has already and has been for years having structured monthly meetings of a collaborative people doing peer support, people doing post-ICU clinics, trying to share data and share knowledge to figure out how to make this better. With that, I'll finish a little longer than I intended to. Thank you so much for your time.
Great. Well, thank you very much, Jack. So while you were speaking, we got a couple of questions that I suppose could probably go to the entire group, but maybe should go to Elyse, if that's okay. So the questions that we got were from Anna Carmack, who said, thank you for the presentation. Is the post-ICU clinic something that you had established prior to COVID, or was it new during COVID? And then the second part of that question is, do you see everyone who had an ICU stay, or do you select certain patients? And I suppose built into that is, how do you select some patients?
Yeah, sure. So the post-ICU clinic at Cornell existed for, I want to say 1 to 2 years prior to COVID. And before I started working there as a fellow, a second-year fellow, I'm finishing my second year right now. So I've been working there this past year, but prior to that, it was just Lindsay Leaf completely alone, who's my mentor, and our clinic was really all of her effort and hard work. So we were seeing patients about every other Monday afternoon. So we saw 3-ish patients every other Monday. That was our volume before. Now we're seeing a lot more patients, and the way that we find them is that the hospital has a list of patients who were basically in the COVID era in New York. You didn't get to an ICU unless you were intubated. So we had no one in an ICU on BiPAP. Those patients were on the floor when we started using BiPAP. We had no one in an ICU on high flow nasal cannula. Those patients were on the floor. So every person who was admitted to an ICU with COVID was intubated. And we have a list of all of those patients. And then I have an amazing, hardworking staff member at our clinic who calls all of those patients and sets them up for an appointment. So that's sort of how I just forward the list to her of our discharges, and then we reach out to them.
Great, thank you. And if you have questions related to any of the talks, please feel free to send them over during the chat. We may defer a couple of them to the end of the conversation just to try to get through the rest of our fantastic speakers. And so on that note, I'd like to introduce our next speaker, Dr. Carla Sevin. Dr. Sevin is a pulmonary and critical care medicine physician at Vanderbilt University in Nashville, and she's director of the ICU Recovery Center. Her talk's entitled, "So You've Been Told to See a Recovering COVID Patient in Clinic. What do you do?" So with that, thank you, Dr. Sevin, for joining us.
Thanks, Dr. Admon. It's such a pleasure to be here. And I want to say that "So You've Been Told to See a Patient" was Jack's idea for a title. I tried to soften it a little by saying you've been asked to see a recovering COVID patient, but hopefully I think at the end of this session, everybody here is going to really want to see these patients. I hope that's the case anyway. So I'm going to tell you a little bit about what we commonly see in post-ICU clinics. So like Dr. LaFond, we had a pre-existing post-ICU clinic. We started ours in 2011 and 12. We started seeing patients. And these problems that we're talking about today have existed long before COVID, but it's really only because since COVID came to light that we've had renewed interest in this area. So if this ends up being a stimulus for people to see more patients in ICU follow-up, that'd be great. And I'm a very reluctant Twitterer here at ICU Recovery. You're welcome to follow me there. So the why is, this is a slide from Jack actually, and he needs to update this because it's pretty old. And I expect this curve to just go higher and higher with COVID. But the why is that we're very focused on mortality, but more of these patients that we see with COVID are going to survive than are going to die. And the ones who survive are going to have really severe problems, a lot of them, not all of them. But lest you think that Sarah, the patient that was described by Dr. LaFond, is in some way unique or unusual, I assure you that she is not. And hopefully you've heard of the post-intensive care syndrome by now. A picture is worth 1,000 words, but the words that Dr. LaFond used to describe Sarah, I think, paint a really good picture of the post-intensive care syndrome, albeit one that is really in early stages. The physical impairments I think are something that we're most familiar with as medical doctors and clinicians, but the cognitive impairments can be extremely severe and disruptive to a patient's life and not that obvious, so we have to look for them. The mental health sequelae, including depression and anxiety and PTSD, are prominent. Poor Sarah doesn't have any family at home to take care of her, but it is very stressful for families even before we barred them from the ICU. And patients who experience a critical illness often have a high burden of chronic health conditions, including not just post-intensive care syndrome type problems, but new diagnoses of diabetes and COPD and high blood pressure and other perhaps less glamorous conditions. So how is recovery different in COVID-19? So far, we've only started to see a trickle of COVID survivors in our ICU recovery clinic. But I think this study from Biren Kamdar, which is pictured in this panel here, is illuminating. So this is an actigraph study. The top panel A is actigraphy, measuring movement of a normal control, who I believe is actually Dr. Kamdar. And you can see it starts around noon. It's a 24-hour epic, and he is, running around, getting lunch, sitting down, writing some notes, leaving the office, picking up the kids, getting dinner, whatever you do, sleeping, getting up, moving. This bottom B panel is actually an average 24 epic of 34 critically ill patients. So this is actually all the activity, same scale, of 34 ICU patients pre-COVID, and you can see they're just not moving at all. So it's really not a surprise that they're going to have a sequelae from that. Now in the age of COVID, add increased sedation. We have had some drug shortages, so many of you may be using benzodiazepines for sedation, even though we don't want to. This, along with the very severe respiratory failure that COVID causes, increases the time on the vent, and a 2-week mechanical ventilation for a young person is really long. We've seen patients even longer. We've had some patients on the vent for 45 days here. Decreased mobility as a consequence of that, and because of the staffing issues that go along and isolation that goes along with COVID, decreased family visitation and stretched resources and staff. So really kind of a perfect storm for post-intensive care syndrome, even aside from the severity of illness that we're seeing from the disease itself. So I'm just going to go through some of the common things that we see, and where you see this little red medical briefcase is going to be some tool that you can use, or that is commonly used to try to assess these impairments in clinic. So this is actually a patient that we saw a few years ago in our post-ICU clinic. He is obviously young. He was in the ICU for 4 months, and he lost 126 pounds. That's probably our record. Sarah's weight loss of 18 pounds is probably because she was a skinny New Yorker to start out with, but our average weight loss is 26 pounds from baseline at the time that we see people a few weeks after hospital discharge, and unfortunately a lot of that is muscle. So of the patients that we see back in clinic, we do routinely do a 6-minute walk test to measure endurance. And unfortunately, at least a quarter of our patients can't walk enough to do a 6-minute walk test. And in fact, I have one 47-year-old patient after flu ARDS whose wife didn't want to schedule the visit because we told her he was going to do a 6-minute walk test. And she said, well, he can't walk for 6 minutes. I said, well, that's why he needs to come to clinic. So down here I have 2 references that you can see all the things that we do in our clinic. This is in no way prescriptive, but if you're looking for sort of a practical approach to seeing post-ICU patients in person, there's some more information for you. This is Sarah Bloom, who's one of our nurse practitioners, and she's the first author on this readmission study, which is second. Alopecia, so skin findings and nail findings, also known as onychomatosis, are really common and really disturbing for patients. These are completely benign and in most cases self-limiting unless you have a really bad pressure ulcer, which is what this funny looking skin flap is. These things will get better on their own, but it's really therapeutic to tell patients that, so they may ask you about this, and the clinical tool here is just your eyeballs. It's easy to just look at that and say, oh, I know what that is. The onychomatosis is just a marker of physiologic stress. And the alopecia may be focal, like here in this, around this pressure ulcer where this patient was paralyzed and had his head on the pillow for a long time. But you can also get a diffuse thinning of hair, which patients find very upsetting. Shoulder impairment, also extremely common and kind of an invisible problem. You will not see your ICU survivors doing this most likely because we never put their hands above their head in the hospital unless we're proning them, and now we're doing that more, so I expect to see even more shoulder problems. A simple range of motion exam, which you can even do on telehealth, can tell you if patients have limited range of motion in their shoulders, and pain is a very common symptom in the shoulder even 6 months after hospital discharges, described in this study by Gustafsson. The global cognition scores in survivors are markedly abnormal, and unfortunately, as you can see from this box and whisker plot, this is from the Pratik Pandahari is one of my colleagues here in anesthesia, and he and Wes Ely led up this brain study in 2013 showing long-term cognitive outcomes after critical illness. And if you're older than 65, and these are medical illness, so this is not people got their head bonked. These patients were coming out with cognition scores in the range of between mild cognitive impairment and Alzheimer's disease. So this dotted line here is traumatic brain injury. This is not good, and being young, I'm not sure if you can see down here, being young, younger than 49 years old did not protect you, unfortunately. So the MoCA is a very commonly used, this is the Montreal Cognitive Assessment tool, is very commonly used to measure cognitive deficits. And I just put this little website here. This is the MoCA website, but they give you a couple different options for remote MoCA testing, including administering the MoCA blind, which you can do by phone, and you can do the whole test actually by telehealth if you have visual, which we're not doing on our initial visits now on telehealth, but can be done. And we know that delirium is the strongest independent predictor of cognitive impairment. So if your patient's been delirious as measured by the CAM for a week, you can be pretty sure they need to see you and follow up after the ICU. PTSD after critical illness, we're still learning a lot about this. This meta-analysis showed about 20% of patients had clinically significant PTSD symptoms at a year. They were more likely to occur if you had some pre-existing psychopathology, more likely if benzodiazepines were used, and more likely if there were early memories of frightening ICU experiences. This is pre-COVID, and I think all of us are going to have some element of post-traumatic stress if this pandemic ever ends, so I expect this to be higher. There's this individual level of post-traumatic stress, and obviously early memories of frightening ICU experiences are going to be pretty common if people are going to the ICU for hypoxia that they know is COVID. There are a couple of different measurements. The IES-6 is a 6-item survey that you can use, and it's also validated for telephone use. We use the PCL-5, the post-traumatic stress checklist, because it maps onto the DSM-5. And then the hospital anxiety and depression score is useful for gauging anxiety and depression. This is art by Nancy Andrews, who was an ICU survivor and did an amazing series of drawings based on her experiences of delirium in the ICU. So a lot of our patients have high need, and they sort of end up marooned between hospital and home, which is where I think the post-ICU clinic can be extremely useful. Most patients will not have access to a intensivist-specific post-ICU program. This is Vanderbilt, and most of the other places where you can find one in the U.S. right now is going to be in a tertiary center. So most patients are going to be seen in their PCP's office if they're seen anywhere. But as Jack pointed out, it's kind of a problem to say follow up with your PCP as the plan if the patient doesn't have a PCP, which is at least 50% of our patients at Vanderbilt. And in other populations, especially now with the additional barriers that COVID poses, many people are not going to be able to get good PCP care after an ICU stay. Plus, we never tell the primary care physicians what actually happened or what they need to do next, so it makes it hard for them to do their job. Annie's going to talk about peer support. And when I first put this slide together some years ago, telemedicine was kind of a pipe dream. Now it's our main gig, and I will just briefly describe how we were seeing patients in clinic pre-COVID, and then a few words about telemedicine. So we were already trying to only see the sickest of the survivors, so patients who had been on a vent, in shock, or had delirium. That's going to be pretty much anyone with COVID who makes it to an ICU. And it's a multidisciplinary team clinic staffed by respiratory therapy, our ICU pharmacist, Joanna Stallings, some array of critical care specialists, including myself, a neuropsychologist, Jim Jackson, and case management. And this is, if you really want the nitty gritty of how we see people, this is just a little flow chart of how they move through the clinic. An in-person new patient visit is about 2 hours, which is frankly all the patients can handle because they're totally exhausted at the end. So we try to pack a lot in there. But the minimum criterion, which I tell people who are interested in starting a post-ICU clinic or a post-COVID clinic, is really just one interested, open-minded critical care person, which hopefully is you. And if you want to see a full rant on my opinions about that, there's this editorial in Critical Care Medicine, which was published last year. But I certainly think that intensivists need to be there. This is a paper that just came out in the last couple of weeks, which is from a qualitative study that several people on this call worked on. But I just want to highlight that two of the big issues that are needed are care coordination and normalization and expectation management, or education, as Jack pointed out. And these are two things that are eminently well delivered by telemedicine. So telemedicine has a lot of advantages. I'll start with the disadvantages. The reason we weren't doing a lot of it pre-COVID was there were still a lot of regulatory hurdles and insurance non-payment, and some of those are better under pandemic rules, as I call them. But there's some natural disinclination to want to see patients on telemedicine when you would prefer to objectively gather data, do a physical exam, and provide certain treatments that you can't do over telemedicine, for example, immunizations. But the advantages are real. So one is, as Dr. LaFond pointed out, we weren't seeing a ton of patients in person pre-COVID because it was really hard to get them back. They're very limited in their mobility, they're weak, they need to have a family bring them. The family member has probably already lost a lot of work, missed a lot of work taking care of them in the hospital. So telemedicine really allows us to reach patients at a critical time point early after discharge. The startup costs are low. You can get a sweet telemedicine setup for less than $5,000, and really all you need is a laptop with a computer with a camera on it. You can pull in your multidisciplinary team members. So we have Zoom integrated into Epic, and I just start the visit and then I link in all my other team members who are also at home. So that's been great. And we get to see family members and the patient's home environment, which can be very illuminating. In fact, as a pulmonologist, I had my first parakeet in the background experience last week. It was very exciting. And then we are right now using telemedicine as sort of a screen and triage visit. So it helps us see who needs a fuller in-person evaluation, and helps the patient see that there are some lingering problems that need to be dealt with. Interview tips. We have to ask very specific questions and listen to the answers. Sometimes patients don't want to know the answer, so nobody's going to say, yes, I'm cognitively impaired. But if you ask very specific questions like, who is the president and what year is it, you are going to find out a lot of interesting things about patients who otherwise seem to be normal, cognitively speaking. You may not know how to deal with the answer, and that's okay. I think some intensivists don't want to see post-ICU patients because they don't know how to deal with the problems, but we're used to being flexible and thinking outside of the box, and we can do that in the outpatient setting too. And then the therapeutic element of the interview cannot be minimized, I think. Just normalizing the recovery process for patients is extremely therapeutic. So this is the Dirty Dozen that Jack showed, and I think it's perfectly fine to use it as a checklist for your first post-ICU, post-COVID clinic, telemedicine or otherwise visits to make sure you're hitting the key points. But keep in mind, we've spent all this time talking about just these two phases, preparation for discharge to home and early home adjustment. But these patients in many cases will be in recovery for months or years. And we need to start planning for that as soon as they get to the ICU, not right when they're leaving the ICU. Just one plug for not only what following post-ICU patients can do for patients and families, but also for us. So I actually get a lot of benefit from seeing patients in the post-ICU period. I learn a lot of things about my ICU care around prognostication, and it's just been extremely beneficial, and this has been shown to be likely to improve the quality of our ICU care if we follow these patients a little bit longer term than we're used to. There are a number of clinics out there, some which are also doing peer support, which Annie's going to talk about in a second. And if you'd like to have more information, I'd be delighted to talk to you about it. You can tweet me, you can email me. I think we're going to try to make these slides available. We have a number of studies in the works trying to learn more, but there's a ton of work to do, so I hope you'll join us. Thank you.
Great. Thank you very much for the talk. Dr. Sevin, I will say there are a couple of good questions in the chat box. Out of the interest in moving right along to the next talk, we probably won't ask them for the entire group, but maybe if you get a second to take a look at them. And for everyone else, we're probably going to run a little bit over, but that's great. I think there's a lot of really fantastic information here. If you need to leave at 9, feel free to sign off. If you have any questions that we don't get to at the end, feel free to email me or otherwise get in touch with us. We'll be sure to pass them on to our speakers. So with that, I'd like to introduce Annie Johnson. Annie is a practicing nurse practitioner at the Mayo Clinic, where her clinical and academic focus has been on post-intensive care syndrome and peer support. She also led the Society of Critical Care Medicine's Thrive Peer Support Collaborative and is here to talk about peer support for survivors of COVID-related critical illness.
All right. Thank you so much. I think you guys had to help me share my screen with my slides.
Yes, we'll do that right now.
Perfect. While we get that pulled up, I'll just jump right in. So I'm going to chat with everybody this evening about peer support and how we can utilize peer support in the recovery of our patients who have experienced critical illness, and not only our patients, but their families as well. And before I jump right into that and into more of the details, I did want to share a quick little story with you guys. It's a patient who actually presented to a post-ICU clinic. You can even advance to the next slider. I don't think I probably have do I have the power? Probably not. A patient who had presented to a post-ICU clinic a while back after several months earlier suffering from a critical illness that landed her in the ICU for a prolonged period of time. She was, intubated on on pressors, the whole 9 yards. And this was after suffering bad complications from an amniotic fluid embolism, actually. And she survived that, and she shows up at clinic, and she showed up several months later after this experience, and it was around the year anniversary of her critical illness. And instead of feeling like Dr. LaFond was talking about, her patient, wasn't feeling that excitement, that thankfulness, that gratitude. She wasn't feeling those things, even though that's what society was kind of telling her she should be feeling. She wasn't feeling that. And remember, this was also the first birthday of her new baby as well. And she was feeling more anxiety, grief, depression, anger. And in fact, it was so bad to the point that she considered canceling her child's first birthday party, so she just didn't even have to deal with any of this. So she brought this up to her physician in the post-ICU clinic, and her physician actually suggested to her that she try to connect with somebody, try to connect with a peer, maybe somebody who had experienced something similar to this that she could talk to. So she did. She was actually able to connect with a woman who 2 years prior to them meeting had herself experienced a critical illness, and they just had the most wonderful conversations. They were able to share stories of their experience with critical illness. They shared stories about what their life has been like afterwards. And then really importantly, they were able to share stories about what life looked like moving forward for them. And even though this ICU veteran was at least 3 decades her senior, they were able to connect in such a powerful way. And it was through this connection and this healing that it really helped put all those pieces of that puzzle together. So she was doing the healing. She was back in a clinic. She was physically healing, but it was really that connection and that mental health healing through that peer support that really got her to a better place. So we can move on to the next slide. We'll talk about kind of the whys and the whats of peer support. So when peer support is done effectively, it can really offer healing through connecting people together who have had shared experiences, and they can share empathy, advice, and stories, just kind of like I highlighted in the story earlier. And group members really develop a foundation where they can give and take support from one another, and they just keep that healing process going and active. Historically, we know that peer support has been effective for other disciplines, so like cancer, diabetes, and patients with mental health disorders. We know that peer support has been effective. In these patient populations, it has shown to lead to improved emotional regulation, empowerment, self-advocacy, which all translate into improved outcomes for these patients. And there is some evidence that suggests that people who have experienced critical illness and then interface with a peer support group do better from a psychologic morbidity standpoint, and they have that increased social support. And anecdotally, all of us out here who have been doing this work and who have been hosting peer support groups, we know that this is helping our patients, this is helping our patients' family members, but there still remains a pretty big opportunity for us to formally explore this a little bit more. So I just want to kind of give you a little bit of a timeline and a peek at actually what's occurring. So you kind of know what's going on in the world right now in regards to peer support, specifically related to post-ICU patients and their families. And it was in 2015 that the Society of Critical Care Medicine launched the Thrive Initiative, and you've probably heard of that before. And it was through this initiative that the Peer Support Collaborative was started. And this was an international collaborative of teams that was really focused on developing various types of peer support to serve our patient population really well. And in 2018, this collaborative published a paper that describes the current models of peer support that were currently being utilized by the sites that were representing the collaboratives. The article, the paper is at the bottom there, the reference. Just in the interest of time, I'm not going to walk through all 6 of these groups, but it's really interesting. This paper describes it really, really well. So if you're interested in a particular one or just want to learn about all of them, read that paper, and it does a great job of describing what kind of work is currently going on with groups across the world right now. Next slide is good. Thank you. Moving on in the timeline for this, it was early this year in 2020 that CAIRO, that has been mentioned a couple of times already this evening, was established. And one of the major arms of CAIRO continues to be peer support. And you can see a sampling on this map here of the active sites in our peer support collaborative underneath CAIRO. So it's pretty impressive. It's definitely an international event, and more sites keep popping up. Unfortunately, after we all launched this together underneath CAIRO now, the world just like suddenly quickly shut down. Everything just stopped. Obviously, the COVID pandemic has had a significant impact on everyone and everything, and running peer support groups was really no exception. social distancing and the necessary restrictions that were put in place across most organizations has really made gathering for group really, really difficult, if not impossible for most of our active groups. So recognizing this, and we can move to the next slide, thank you. Recognizing this, the groups that are involved in the collaborative at Cairo, we've been talking about this and we've been looking at this, and we really knew that now more than ever, our patients and families need support. So in the time where it's most difficult to give the support, especially in the way that we knew how to before, our patients are needing it more than ever. So a lot of our sites that are in our collaborative have really put their heads together and gotten very creative and thought, how can we move our active face-to-face peer support group into a forum, a platform where we can reach people where they are, which is mainly at home. How can we go remote? How can we get online? And a lot of our groups have successfully done that. It's been very impressive. And so we put together a quick start guide or 6 quick tips to share with others. So this is meant to be just helpful tips for you to take away. So if you're interested in creating a brand new remote peer support group, these will be very helpful for you. If you currently have a face-to-face peer support group and you want to move it online or remotely and you just haven't quite known how to go about doing that, I think you'll find these to be helpful as well. So I'll break these down really quickly here. The first tip is to research. And when we say research, we mean research your organization and what is already available to at your organization. You might be pleasantly surprised. There might be something already in a nice little package for you to take and start using with your patients. So look into that, and also be aware of any restrictions that your organization might have in regards to platforms that you choose to use, because trust me, you will save yourself heartache and headaches down the road if you do a really good job of researching this right up front. The second tip is to choose your platform, and there are multiple different platforms, right? So of course we can do video just like we're doing here with like Zoom, GoToMeeting, those types of things. Telephone, the good old telephone, and online blog sites, Facebook postings are different types of platforms. Now, the thing to really consider with choosing the right platform is to really know the group that you're targeting. So know the patients that you are inviting into your group. For example, video works really, really well if you have a smaller, more intimate group. So if you've done group and you've been holding group and say you're like cohorted, so some people group like 5 to 8 people together and they walk them through a 6-week program. That would be a really great group to do with a video. We all know that if we get beyond those numbers, it can be very difficult to hold an effective group through video. So just things to keep in mind. Phone works really well for people who either have no interest in video or don't have access to video technology. And then the online group is very wide reaching. So if you're more interested in just reaching the masses, reaching as many people as you possibly can, online forums work really well for that. They're a little less, they don't work quite as well for the more intimate cohorted groups, but they do have that really wide reach. The third tip is to choose qualified moderators. So really popular choices for this include our social workers, hospital chaplains, psychologists, and even ICU survivors are very motivated to come back and do this as well. The key here is to remember, obviously we all are very well aware that critical illness is traumatizing. And so choosing somebody who has skills with trauma-informed care can be very helpful. The fourth tip is to establish ground rules. This seems pretty simple. It's really not too different than the ground rules that we establish for our face-to-face groups. The main goal here is to protect privacy and respect of all of our group participants. There are a few things, however, that are unique to the remote and online world that we want to really think about. And the first is to protect the privacy. So we want to make sure that when people are at home and they're doing this from their home, that they are in a place where they're the only ones in the group and the rest of the family isn't hearing them. So for example, instead of setting up in the middle of the living room where everybody in the family can hear what's going on with the group, really recommend to your group members that they be, you know, in a room, maybe with a door that can close, or where the AirPods or, you know, the earphones, where that conversation stays within the group. And so it just is really respecting the privacy of the group. The second really good tip that came out from our discussions as a collaborative was about video and showing your face on video. So some people are reluctant to do that, but the one suggestion was that moderators always show their face during group time. So if the participants really feel that they, you know, uncomfortable showing the face, that can be their choice. But to really establish that trust and that connection between the moderator and the group, the suggestion has been to really have that video on, that video in place. The fifth tip, logistics. How often and for how long are you going to meet? These are some things that you can kind of test out. So you might start out with, you know, ideas of doing this one way. Oftentimes, a lot of our groups do meet one time a month for an hour. And then just get feedback from the group. So kind of let your group members guide you and steer you in the right direction there. And then the sixth tip is to plan for the in-between. And what we mean by that is to have resources for your group members after group and in between meetings. So right now, with our social structures being so different than they are, our support systems are just non-existent in a lot of ways. So, you know, people aren't going to the gyms, people aren't hanging out at the coffee shops or the bars with their friends. So support systems are really suffering right now. So just simple things like having favorite videos or books or articles, things for people to read that will provide that extra support for these patients in between those times of meeting can be very, very helpful for your group members. All right. So we know that peer support works. It works for other disciplines, and we really have no doubt in the effectiveness of this for our patients who have survived critical illness. And this is really evidenced by our patients who participate in the group. And so I really wanted to share this quote with you from the patient that I introduced you to at the beginning of the talk. She was reflecting. She actually this was a message that she gave to the woman that she had connected with. And she said, "Thank you for your beautiful messages. I have read the messages you sent already many times. They carry so much meaning because I feel that you understand things that few others do. Last night, I read what you had written yesterday out loud to my husband. When I turned to look at him after I had finished, I saw that he had a tear running down his face. He said, I have not known how to help you. We both feel such gratitude for your kindness in reaching out to me to give me hope for the road ahead." And one more thing about this that I didn't disclose earlier on was that this was actually an online connection. So for anybody that's maybe questioned, you know, how much can we really connect? How much can we really do with these remote support groups? Is it the same? Is it going to be benefit? This is such a great testament to that. And these women were states apart from the Midwest all the way to the West Coast. So we can still provide very healing and very powerful connection, even though we're not physically together right now at this time. You know, setting up your own group, it doesn't have to be difficult if it's something you're interested in, and it can be done in really a relatively short amount of time. Following, you know, those quick 6 tips that I just shared with you can be a really helpful first step in that. But I know that a lot of you are feeling stretched with resources, and that's a very real thing. A lot of places just don't have the bandwidth to do something like this. So I really urge you to not hesitate to reach out to teams who are already doing this work, because there is a real potential that exists to connect with others and to get your patients the help that they need. The next slide here is just a list of all the amazing people that I have gotten to know over the past several years here, and that have had great input into all of this and all of these tips and this hard work and are doing this great work. Many of these people, all of these people are either running a peer support group and or a post-ICU clinic, and they can be invaluable resources to you. This is something that you are also interested in doing. And then at the end here, just a final plug again for Cairo, for the collaborative. If you are currently running a peer support group and you're interested in joining our really productive, fun international collaborative, it's actually open to applications, and that website is at the very bottom there. You can just click that. That gets you right to the application. If you're wanting more information about the collaborative, or if you're wanting to connect with anybody within these to pick their brains a little bit more about the work that we're doing, you can email the Cairo email there. My email address and Twitter handle are right there. And then finally, I want to give you the website for our Mayo Clinic Connect group. The picture at the top there is just a little snip of what this looks like. This is an online post-ICU or ICU, so peer support group that is wide open to anybody and everybody all over the world. Anybody can just log on to this. So please share this widely, share it with your colleagues, share it with your patients. We would love to help out in any way that we can. And with that, thank you so much, and looking forward to the discussion.
Great, thank you. Thank you very much. Let me close the presentation here. So it's 9:12 p.m. We've had a fantastic and thought-provoking hour and 12 minutes. I want to be respectful of everyone's evening, at least here on the East Coast, and maybe early evening on the West Coast, and then other times of day around the world. We have had a fantastic group of speakers. I'd like to thank them again, Dr. Elyse LaFond, Dr. Iwashyna, Dr. Carla Sevin, Andy Johnson, and all the ATS staff members, specifically Liz Guzman, Rebecca Fish, Lauren Lynch, Eileen Larson, and then other members of the community that have put these sessions together, Laura Crowdy-Alexander, Nirav Shah, Viren Kaul, Sushma Cribs, and Isabel Pedraza as well. Thank you to all of you for joining us and then for sticking through the session. If you have any questions, I sent my email address out to the chat group, so please feel free to reach out to me, and I'll pass along your questions to our speakers. So with that, please join me for a virtual round of applause for our presenters tonight, and thank you all. Have a great evening.
Thank you.
Thank you so much.
Thanks.